I'm from San Diego originally. I'm 45 years old, and I have a huge family, 5 kids. We live in La Mesa, which is about 20 miles from the water, from the coast. And I was riding my bike at least 2 or 3 times a week to the coast and back home. And I can no longer do that. I can no longer ride around the block, let alone to the beach.
I used to snow ski quite a bit. I used to body surf. I used to run half marathons 3 times a year. Oftentimes they think that I'm blind because I have this harness on this dog, so they think he's a guide dog and not a service dog.
I have a 2.5-year-old little girl and a husband who's in the Navy. I stay at home with my little girl and we live a very hectic life. And I'm also expecting, pregnant.
I was born and raised in San Diego. I'm a mother of a 14-year-old boy who's very active in baseball. You know, they automatically say, but you look so good, or but you don't look sick. And while that's a compliment, I sometimes, you can't help but take it as, well, I wish you knew how I felt inside. You don't know what I go through on a daily basis. I sometimes wish I looked like I felt.
I also used to love to sail, but sailing, beyond just day sailing, is dangerous for someone in my condition to go out on a sailboat and sail offshore, for example. We can go along and sit in the cockpit and we look perfectly happy. And I am perfectly happy, but I'm of no value to the captain of the vessel. And that kind of bothers me. So this is not what I perceive retirement to be.
Hi everybody, I'm Dr. David Granite, and welcome to Health Matters. Today we'll be talking about multiple sclerosis, known commonly as MS. Approximately 400,000 people in the United States acknowledge having MS, and approximately 200 cases a week are diagnosed. This requires an expert, and today we have on with us Dr. Jody Corey-Bloom, a professor in neurosciences at the University of California, San Diego. Welcome.
Thank you.
Now, I thought that was so funny that it said acknowledge having MS. And I think that's going to be a thread that runs through our discussions about what really is MS when people want to admit they have it or not.
Yeah, I mean, exactly, David. It's really a problem. I think that it's one of those diseases that strikes young people. It strikes them really when they're trying to be productive, when they're working. And so it oftentimes is very difficult for them to acknowledge that they may actually have a neurologic disease.
All right, so let's debunk and educate a little bit. What is multiple sclerosis?
So MS is a neurologic disease, and it's a neurologic disease that affects the central nervous system and the spinal cord. So it doesn't affect nerves, it doesn't affect muscles, but it definitely does affect the control centers of the nervous system, the brain itself, the brainstem, and the spinal cord. And what happens in MS is that myelin breaks down. Now, myelin is a fatty sheath, a covering, if you will, that protects the axons or the nerve cables for each of the nerve cells in the brain. I like to think of it like insulation, really, insulation for wiring.
Sure.
And so what it does is keep the signals on track. So one nerve cell trying to talk to another nerve cell, it keeps those signals on track. In MS, that fatty sheath, that myelin, is actually attacked by the person's own immune system, and so it breaks down. We form plaques, actually, in the brain, in the brainstem, and in the spinal cord. And as a result, people's conduction, or the sending of messages from one nerve cell to the next, is interrupted.
Now, we've known about MS for a long time. People were able to do pathology and see that there were these lesions going on, but we didn't know what caused it until relatively recently in the history of mankind.
And that's true. I'm not sure we actually know what causes it now. We think that there may be many viruses, actually, that are capable of inciting the response. We know for sure that a person's risk of developing MS really depends on where they lived the first 15 years or so of their lives, because the risk is actually greatest in temperate climates. And so if you lived in a temperate climate until you were 13 or 14 and then moved to the equator, you would still carry the risk of that temperate climate. We think that there are probably certain viruses that exist there that can get into our immune systems and really upset them, so that the immune system, which is usually a good thing, usually a surveillance system for us, usually looking around the body and the brain for cancer cells and infections, now actually turns on itself and actually views myelin as the enemy. And so it actually attacks that myelin.
So we have to talk about this. Can you catch MS from someone else because they have a virus that will come to you?
Oh, good question. No, actually MS is not contagious at all. And we think that someone actually has to be susceptible. They have to have a certain features of their immune system that allow that virus to actually get in there and perturbate it, if you will. But interestingly, when we look years later for the virus, it's no longer there. We see some of the footsteps of that virus having been there, but it's no longer there.
Is there a genetic component to this in terms of the susceptibility?
Yeah, there's to some degree. It's not a genetic disease. We shouldn't think about it as an autosomal dominant disease, for example. It's not a disease in which if a parent has it, a child is definitely going to have it.
What else?
Well, that's where we've kind of fallen down a little bit. We don't really know what else. We do know that it seems to occur in women more than in men. Probably 2/3 at least of patients are women. We also know that it tends to occur in young women and in young people in general. So, you know, it's actually much more likely to hit people in their 20s to 50s. Now, having said that, I should tell you that I have teenagers who I've diagnosed with MS, and I have people in their 60s and 70s who I've diagnosed with MS. So it doesn't mean that it's exclusively in people in their 20s, 30s, 40s, but it actually does seem to appear most frequently at that time.
So we've talked kind of about what it is, what the risk factors are, but we haven't talked about what the person feels or what the symptoms are that may even lead them to think they might have it. What does MS do to the person who has it?
Well, and again, this makes it a little bit difficult because MS can be very varied, and I think that's one of the reasons why sometimes patients are frustrated, because they feel like it took the neurologist or whomever too long to maybe make that diagnosis. One of the problems is that the symptoms themselves can be very varied. In the most common scenario, it's a young woman who presents with problems with vision in one eye, visual loss in one eye. So they may actually notice that their vision dims and that over the course of a week or two that they actually lose vision in that eye. Sometimes it's painful. They end up going to an eye doctor, someone like yourself, and they're often told that they have optic neuritis. Now sometimes they're told that the ophthalmologist doesn't see anything, and in those cases, as you know, it may be retrobulbar neuritis, so behind the optic head that's really the problem. But they lose that vision, and you know, in good situations, much of that vision or all of that vision will ultimately come back over the course of a month or two or three. Then they may go for periods of time, and the next time they may have a symptom, it might be something like numbness or tingling of an arm or an arm and a leg, or even a whole half of their body. Sometimes they'll get numbness or tingling of their trunk, you know, one side of their the trunk of their body.
Now, I mean, as a doctor, numbness and tingling sounds so vague, or even sounds like panic or someone who's just anxious. Does it get mistaken for that in a young, otherwise healthy woman?
Yeah, and I think exactly that's one of the problems. Sometimes people are told that they have carpal tunnel syndrome. Sometimes people are told that they may have a pinched nerve, or that they may be anxious, or as you mentioned, that it might be a panic attack, those kinds of things. But I think if they get a careful neurologic exam, especially combined with the history of having lost their vision a few years before, and now maybe having some numbness or tingling, we usually then initiate workup in somebody who seems like they might actually have MS.
But some of these, I mean, they're just so vague that I'm not sure most people would even think of.
Yeah, things like slurred speech, that's actually much more specific. Weakness of an arm or a leg. Problems with articulating words, coming up with words, word finding. Cognitive problems in a young person who isn't depressed, for example. These are all things that make us start to think that maybe there might be a neurologic problem at the base of it, and that it might be MS.
My early symptoms were optic neuritis. Back when I was 12 years old, I lost the vision in my left eye. It wasn't until I was 24 years old that they did an MRI to determine that it was indeed multiple sclerosis.
Neurological diseases are odd in the sense that, I mean, we may be able to move our muscles, but we can't communicate with them. What our brain is trying to tell our muscles is not going through the little motions of getting there.
My walking, I wasn't tracking straight when I would walk. We went out to eat. My mom thought I'd had too much to drink and I only had a beer at dinner. So then I noticed when I was working, my eye was kind of twitching. It was a little bit different. And then the other thing that was most noticeable was bladder. You have what they call old brain, new brain. And people with MS, the new brain is really affected and the short-term memory is really affected. And you do a lot of word searching and it gets really frustrating.
I would say almost daily I think about, how it's affecting the kids, my poor wife. Even though it's not affecting her, she's not, she is dealing with the MS, but I just feel bad for them. They're not getting, I feel like I'm not, 100% dad.
I worry about my son. Being 14 years old, he probably worries a little too much about me than a 14-year-old should, but I think it's a good quality that he has. He's very compassionate and caring and loving, and that's what I would want in a son, and I luckily got that.
I was diagnosed in 1996, and at that point I was walking strained, let's say. I appeared as if I was intoxicated when I walked, but I didn't use any appliances, canes or walkers or anything. And then obviously that progressed to the point that I was using a cane, and from there that progressed to where I was using a rolling walker, and then that progressed to my current condition, which is a wheelchair, which I am doing my best to reverse that cycle and be out of the wheelchair at least part of the day.
So we have a person who may live in an area where there's a higher risk, maybe has a family member that had some problem along these lines. It's generally in what we would consider the prime of life for health, between 20 and 50, before we expect most things to start happening, and they start to get some of the symptoms that you discussed. So they're getting a little bit nervous, right? The next step then is going to be, how do we make a diagnosis?
Yes, and the diagnostic process itself really requires that people have neuroimaging, brain MRIs, sometimes MRIs of different parts of their spine. Sometimes we have to do a lumbar puncture or a spinal tap, which most people are actually very concerned about or very nervous about, as you might imagine. Believe it or not, the diagnosis itself is actually still a clinical diagnosis. We have tests that can actually show lesions that look like they might be demyelinating, but sometimes those lesions are not specific. And you may be surprised to find out that people with migraines can actually have small white matter lesions. So
when we're talking about an MRI and these lesions that you see, if I took all comers in the population and I just randomly MRI'd people, how many people would have a lesion that you would find at that moment, one lesion that it would make everybody sweat because everybody would get nervous? I mean, how many people just walking around with a lesion, quote unquote?
Yeah, I think I don't know those numbers, but probably a lot. And the reason I say that is that a very interesting study was done where 100 patients with migraines were actually looked at with brain MRIs, and many of them had not just one lesion, but multiple white matter lesions. So I think it's actually quite common because remember, the MRI isn't specific for MS. The MRI just shows small areas of the brain where there may be more water content, more protons, for example. So it's really not a specific lesion. I think that's the message that we need to get across, that white matter lesions do not equal MS necessarily.
All right. At what point do you have enough information?
Going back to that woman that we talked about, the woman presents with optic neuritis when she's 25. 3 or 4 years later, she develops numbness and tingling of one side of her body. We examine her neurologically and find that there actually is numbness and actually maybe a little weakness that she wasn't even aware of. So that would be 2 episodes of neurologic problems. We get that brain MRI. We see white matter lesions that are not just nonspecific. They're actually located in the areas of the brain where MS lesions are most likely to occur. They're oriented as MS lesions are. We may get that spinal tap and find that there are oligoclonal bands in that. Oligoclonal bands and increased IgG synthesis are usually 2 hallmarks in that spinal fluid of MS. So we use that. And then, I think it's putting it all together at that point in time. The age of the patient, the kinds of episodes they had, the appropriate white matter lesions, and the findings on spinal fluid. I think most neurologists would be comfortable at that point saying, yes, I think this definitely is MS, and actually that patient would meet clinical criteria for the diagnosis.
Yeah, and we've got all this data now on our patient, and you've got this information, and you're going to sit down with them in front of you in your office and say, you have MS. And they're going to have a whole bunch of questions for you. They're going to ask you what that means for the rest of their life, and you're going to have to break down, because all MS isn't the same. So in order to give them a snapshot of what to expect, you have to break it down. What are the different types of MS?
Yeah, well, first I want to tell you, that's probably the hardest moment for me. It's one of the most difficult things that I have to do, is tell people that they have MS. And the reactions, as you might expect, are very varied. But, it's not uncommon that people cry, and even men. And I think it's because, remember, we're used to being invulnerable, 20s, 30s, 40s. We have nothing wrong with us. We have no illnesses. We have no problems. And so this is really, really difficult, and I really try to save a lot of time for it because I know it really impacts the patient tremendously, and they're often quite emotional about the whole thing. They have a lot of other things on their minds about it. It's not just their health. They're not just upset for themselves. MS is not just an individual disease. It really impacts on families. And like I said, because they're young, many of them are in childbearing years, and they were just, they'll tell me, well, we were just planning on having children. What can we do about that? Can I have children? Well, am I not going to be able to have children? Am I not going to live to see my children grow up?
Who's going to take care of my kids?
Who's going to take care of them? This is part of what we do. I think in most fields there are those really difficult situations where you really have to sit down there and kind of explain to people about the disease, about the natural history, what they can expect. I don't tell everyone immediately all that might play out.
Initially, when Mark was diagnosed with MS, it kind of was like a slap in the face. We went to see the neurologist and basically sat us down, and he said, you have MS, here's some pamphlets on it, and we'll see you in a year.
In the beginning, I would say for the first couple of years, it was just kind of an identity crisis. Does this mean I'm going to be bedridden now or confined to a wheelchair? Like, what does this mean for me? And yeah, I'm really sick and I have this awful disease, yet I feel pretty good. And, it was just a major identity thing, because it was also realizing that I now have a disease and I'm never without that disease. Like, I can never just wake up today and say, okay, today I'm not going to have MS. Like, it's with me every day.
As a guy, there's not been really anything difficult. I've just dealt with it and stuff. I would say for the most difficult part would be on my 5 kids and my wife. The poor kids having to deal with me, seeing me running around, maybe being their soccer coach, and now I'm the guy sitting on the sideline, no soccer coach. So that's probably been the hardest, dealing with the kids. That's another unfortunate part of this disease is now I'm disabled. I'm Mr. Mom. My wife works. Whereas before, she was staying at home with the kids, and I was working like 20 hours a day. And now I'm staying home with the kids. I'm Mr. Mom.
The most difficult part is how total it is. It affects everything that I do, whether it's something very simple, like getting dressed in the morning or taking a shower. I'm unable to balance myself, or I'm unable to move myself to wherever I need to be. It's so pervasive. Everything you do, the most simple task is complicated because of MS, or at least at this point.
You know, when I went to medical school, if you were diagnosed with MS, people would say things, doctors would say things like, well, go get a wheelchair, you know, kind of a thing. I mean, horrible. And I think that that's not what we're about today. That's not what we're talking about. I'm pretty emphatic about that. I feel very strongly about it because I think for the first time we really have treatments and treatments that work. And I think it's really important to get on treatment early and to actually be aggressive, you know, about the disease because what we think, at least, is that with treatment, that people are going to live very healthy and productive lives in the main. There are some people for whom that won't be true, but largely we see people leading very productive lives. And actually what I like to do is tell people about that. I like to tell people that many of my patients are still working. I like to tell people that I have actually a triathlete as a patient. I like to tell people that I actually have a surgeon as a patient because I think that this is really the message I want to give, that in fact it's really possible to go on with your lives, and that I think right at that moment, right at the moment of diagnosis, everything feels awful. The good news is, as you said, I've actually been doing this for quite a while, and so what I also like to share with them is that about a year later, I see totally different people, totally different patients, totally different families.
Different how?
Different in that, you know, they're taking medications, and not just pills, they're taking injectable medications that a year before they didn't think they'd be able to do.
It was very difficult for me to consider starting a family. That was one of my most major concerns upon diagnosis. I always knew that I wanted a family of multiple children. And that was one thing that I really wanted to clarify with my neurologist, is this something I'll be able to do? And even she wasn't able to give me a direct answer at the time because, again, no two cases of MS are alike, so how was she to know what my course of disease would be as opposed to any of her other patients? So she couldn't answer my questions when I would ask her, can I have children? Like, it was just kind of more like, you have to see how you feel. And that wasn't enough for me to say, oh, but then I realized after a while, I feel pretty good, like why wouldn't I have children? This has always been my life's goal and my life's plan. Why does that have to change now?
You just become the master of adjusting everything. You have to in order to, you know, to make your life, your quality of life good, you have to do things differently. There's kind of a pre-MS way that you did things, and there's a post, which after MS.
MS doesn't have me, and I don't think MS has our family because we still play softball, we still play soccer, we're very involved in all sports, and Mark was a football player. All of our family nephews have scholarships, and so the children keep going, and Mark attends as much as he can.
You've got to be really smart when you have MS because your energy is very limited, so you don't want to waste it. I have a scooter. When I get the mail, I use my scooter if I take out the trash. I only mainly use the walking with Reed for short distances, like going to my car. I take him to church, and I put on his harness and we go.
I have these trek poles, and primarily these were used for like if you're hiking or walking in the snow or whatever, and it's a great thing for me, for balance. Trek poles.
Feel free to ask. I wish more people would ask me what the situation is, because that is positive. That's recovery for me. If I can talk about what's happening, that's beneficial to me as a person.
I think having a good doctor who has helped get them through all this is incredibly comforting. And I think being in a place where they know they have an expert, where they're getting good treatment, allows them to have that peace of mind that they're in the right place and that things are going well.
I think that's true. I hope that's true.
I know it's true, so there's no doubt about that. The patient who comes in uneducated, you educate them, they get educated about themselves. You talked about working, and is there a support group for people so that they can talk about how do you handle work, how do you handle it when your MS pops up? Are there people they can chat with?
Yes, and there are actually many support groups. So, there are many support groups, and I think this is probably a good time to mention the National MS Society.
When I first was diagnosed, I knew they were out there, and I did a little bit of research on them, but I wasn't fully, I don't think, ready to accept them into my life. But since doing so, I've become very active with them, with volunteering and participating in their different events, and it's been great. They've been very supportive.
In order to keep myself in tune with what's going on, I do a lot of internet research, the National MS Society webpage, current research that's going on. And we also do things in the MS community together, such as the holiday brunch. We had recently gone to a couples retreat for MS.
When I was first diagnosed, one of my first contacts was the National MS Society here in San Diego, and they were very helpful. I went to a newly diagnosed seminar, learned a lot about MS because I knew nothing of it when I was diagnosed, didn't know what it meant, didn't know how to spell it, didn't know what that meant for my future. So learning about it and meeting other people that were just diagnosed as well was quite helpful.
I'm more the type of person that wants to know, okay, what are you doing to cure this disease? And the skeptic in me is going, you have raised over the last 100 years millions, possibly billions of dollars, and what has come of that? Accelerated Cure Project, ACP, I donate and volunteer for them because they are looking to find a cause for MS, and they're looking at it from a very scientific perspective.
I'm a pretty big fan of the MS Society. I think that they do a lot to help people with MS. And by going to some of their functions, you get to socialize and see other people with MS. And sometimes they have pretty good food, too.
We have different kinds of support groups. We have support groups for newly diagnosed patients, and as you can imagine, that's important.
Wow.
People who are newly diagnosed have very different issues as compared to people who have had the disease for a period of time. We have support groups for invisible symptoms. I like that one because the suggestion is that it really doesn't look like you have MS. I mean, many patients really want to work, want to be there. And actually, I have a lot of patients who don't disclose to their employers that they have the disease at all and want to continue carrying on without anyone knowing that anything's going on.
I was with the bank at the time, and I pretty much denied having the disease, and I ignored having the disease. So I didn't go to my staff and broadcast that I had multiple sclerosis. I just went through, I had to go to the physician or I had to go get an MRI, but I didn't go into a lot of details. The bank never knew, to be honest, that I had multiple sclerosis, and I was planning to take an early retirement. And so as far as they were concerned, they never knew.
Sometimes I forget that I have a disease, and that's a really good thing. But sometimes I do have to take a step back and ask myself, ooh, should I really be doing that? Should I really push myself? Because I'm very active and energetic and involved in different things. And so I think that's the hardest part, is during hot summer months when the heat's really bearing down on me, I really have to take a step back and discipline myself to say, no, don't push yourself anymore. Relax your body a little bit, cool off, whatever the case may be.
The general public is really confused. They don't understand. Why are you in a wheelchair? You look like you're able to move about. And I'm able to stand or transfer from the chair to the wheelchair to a fixed chair. But I can't walk. So I can shuffle. It's hard to explain. I would like to see a lot more education as far as what the general public knows.
A difficult part about having MS is that it's so invisible sometimes, that people expect you to look and act a certain way when you're sick with a disability, when a lot of times the symptoms that I have are invisible indeed, are not seen just by looking at me. You can't tell that I can't see out of my left eye. You can't see that I have an implant in order to empty my bladder regularly. A lot of things that people just don't understand by looking at me.
How much depression do you see? Do these folks need to be treated for the secondary aspects of the disease?
Yeah, so depression I think is a major issue, and I think that I would estimate that about 75 to 80% of my patients are on antidepressants. And, I look at it as a very positive thing. I know sometimes patients feel like they don't need that crutch, they don't want that crutch, they don't want the stigma of it. But I really try to encourage them to recognize that it's a chemical imbalance, it's a problem, it's a lot to get through, and that for at least a time, maybe just the first year, or maybe the first 6 months, that this will actually help them. An interesting side effect of the medications often is that it gives people some energy too. So if fatigue is an issue, which it often is with MS, sometimes some of the more activating antidepressants can actually help with fatigue. They can help with cognitive problems. Sometimes people find that attention and concentration fails, even in the earliest stages of MS. And so I find that some of the activating antidepressants can be really helpful.
Well, and depression alone can make it hard for cognition.
Oh,
Forgetting about
depression.
MS.
Depression really can make it hard, just in general. As you can imagine, some of the things we really encourage people to do, develop an exercise program, get really active, do things. With depression, it can be really difficult. There's fatigue, there's depression, they don't want to exercise, they don't want to, kind of even do some of the things that actually can help to make things better.
I found with managing depression as well as emotional state of health, I've really had to build a partnership with my doctors, and yeah, I have had to be put on antidepressants in the past. That's also a possible side effect of the different medicines that I'm on, I realize, but it also could be because I have MS and I'm depressed, so it could be many things, but I have found that in being communicative with my doctors, we've been able to get over that hump and use the best treatment out there for me.
But you have to focus on what you can do versus what you can't do, because if you focus on what you used to be able to do or what you can't do, then you're going to start getting bummed about that.
So we know this is going to hit people hard, but we just did a little end run around the different types of MS. So to me, whenever I encounter something novel that's a little bit scary, knowledge helps me get through it. So let's give knowledge about what the different types of MS are and the
Sure.
different subcategories.
Yeah. So the most common type of MS is what we call relapsing MS. And we used to call it relapsing remitting MS, but we don't call it that anymore because the suggestion, at least from that title, was that somehow it all remitted, it all went away. And so we thought that was actually not a good message to send. In fact, it is a relapse or an exacerbation or an attack, and we call that relapsing MS. Oftentimes, much of it goes away, so the remitting part makes some sense, but it doesn't usually all go away. If it all went away, nobody would worry about having MS. So
Right.
we say that about 50% of people, after about 10 years, enter into what we call a secondary progressive phase. And during that phase, we tend to have fewer attacks, but a more slowly progressive course. And quite honestly, that's what we're trying to alleviate or eliminate, I should say, with disease-modifying therapy. One of the reasons that we really encourage people to get on therapy early is that so people don't get into that secondary progressive phase. We really feel that it's possible to keep people from entering that secondary progressive phase.
Not just push it back.
Right. And then there's really probably the third most common, and it's not common at all, is something called progressive MS or primary progressive MS. And that's actually fairly rare. Probably doesn't hit more than 10% of people. Seems to come on later in life, seems to be associated with slowly progressive difficulty with walking or gait. And so this is weakness usually of both legs that comes on slowly and progresses very, very slowly. Tends to affect males more than females, so a little bit different from that point of view.
At the very beginning, somebody's sitting across from you in your office, the odds are they have the relapsing.
Exactly,
type.
yes.
Do you tell them that?
Oh yes, and actually the fact that they've probably had a relapse, or if they've had a relapse to come to me, or 2 or 3 relapses, they usually are relapsing MS, because most people really start out with relapsing MS. And for them, the news is actually great. For them, we have many treatments, and these are disease-modifying treatments. These are not treatments that just help with the symptoms. These are treatments that really try to change the course of the illness. These are usually injectable medications or medications that are what we call infused. They're actually put in by vein. And there, 3 of the medications that are on the market now are what we call interferons. Those medications are either given subcutaneously, so with a very shallow needle, a very short needle, much like an insulin needle actually, into the skin, into the fat actually. And those are given either once a week, but that one's actually not given with the short needle, the once a week one. That one's actually given with a deeper needle. Or with the shorter needles, they're given 3 times a week or every day. So the actual intervals differ, but those are interferons.
These drugs that we first started talking about are interferon. It sounds like it interferes with something. Does it have side effects?
Yeah, so the interferons do have side effects. The interferons can have flu-like side effects. Those are probably the most common side effects that people will get. Sometimes they get headaches, they get aches and pains, those kinds of things. There is another class that I was actually working my way toward, which is not an interferon. And for people who think that they really won't be able to tolerate the flu-like symptoms, we often recommend Copaxone, which is actually a non-interferon. It's thought that the interferons actually help to seal the blood-brain barrier, and in doing so actually keep the immune cells from getting in there and inciting the inflammatory reactions, the attacks on the myelin.
A very clever approach.
Clever approach. Copaxone, on the other hand, it's thought that several things might happen. That one, that it may be influential in changing the lymphocytes, part of the immune system, the immune cells a little bit, so that they go from being an attacker to actually helping the situation. And it's also thought that they may act as a decoy molecule, so that the immune cells will actually attack the Copaxone molecule as opposed to the myelin. I should also note that there are actually 2 other medications on the market, and they have been approved by the FDA. And these are not injected by the patients, they're actually infused, and usually in an infusion center. One medication called mitoxantrone or Novantrone is actually marketed for prostate cancer, but has actually been evaluated in MS clinical trials and has actually been approved by the FDA for MS. And then another one, Tysabri, which is actually a monoclonal antibody, and that's actually given every 4 weeks and also infused in an infusion center.
I'm listening to you talk, and all I can think about is that there's no way anybody who's not a neurologist who deals with this all the time could figure this out. That a patient alone can't, they need your help, they need your advice, they need your input as a team to work together to figure out what's going to work for them, because there are these series of options.
Yeah, and I think that's true. I mean, I really do think that's really true. I think people should, if they have MS, I think they should be working with a neurologist.
Now,
you know, even preferably an MS specialist, but definitely a neurologist.
Having a good relationship with my doctors throughout this 7.5 years of having MS has just been imperative to my success of symptom management and being I email my doctors if I need to with different things that come up, or I keep a notebook of all my questions, because I really have found that having an open relationship or a good communicative relationship with them has been crucial to my symptom management and my overall well-being.
Having a relationship with your neurologist is huge. I always talk to patients, and the first things I ask them is if they have a close relationship with their neurologist. If they don't, I tell them to find another one, because you're going to spend a lot of time with this person. You need to feel like you can trust him and, you know, listen to what he has to say, and want to be able to believe what they're going to tell you is right. You know, a lot of times they might give you, 3 or 4 different options and say pick one. And, you know, it's a lot better if they can actually explain to you what the medications do differently.
He felt that the side effects outweighed the benefits, so he didn't start me on anything, but that has since changed. You know, this was 10 years ago. Now you get on the ABCs right away because they think that it can stave off the progression of the MS.
I feel the drugs have been very helpful. both with energy, and I'm hearing good things on the MRI reports, like the scars are shrinking, stuff like that. I have I have an injector. Otherwise, I couldn't do it. I couldn't press the plunger. In fact, when I first started, my wife was giving me the injections because I couldn't sit there with the needle.
In the 7 years now that I've been diagnosed, I've tried only one treatment, and it took me about a year to begin that treatment. I was pretty resistant to drug companies and everything that they made available for people with MS, and I was very just uneducated as far as what's out there. To do my injections, I actually go to the infusion center at the hospital weekly. I'm really not, I don't think at this point I'm not very comfortable self-injecting. I'm not, because it's a pretty deep shot, so I'm not open to that right now.
I've been on basically every MS therapy, starting with Betaseron, the first that was available, switching to Avonex. I've been on Copaxone. I even did the chemotherapy, the Novantrone, for a couple years. And I'm at a point now in my MS where nothing's really working for me at this time.
I know what an axon is, I know what the nerves are, I know what myelination is, but I don't need to know all that. And of course, we're all looking for a cure. We're all at a certain level of denial.
So we've talked about disease-altering medications, but they have symptoms. What about the symptom-altering medications or approaches?
Good. Yes, and I think that that's really a very, very important part of treatment. You know, MS is a chronic disease in the sense that things change, things happen, you know, sometimes more frequently than others. So some people are very stable for long periods of time. Other people, as you mentioned, have lots of symptoms. And one of the things I really like to, you know, spell out to patients is the fact that these symptoms are treatable. So don't just live with them. You know, don't just endure them. You know, if they're having fatigue, let's talk about it. If they're having depression, you know, let's talk about it. If they're having cognitive problems, there are medications to try. Pain, if they're having pain, there are definitely medications to try. It's interesting, I know that there are a lot of neurologists that don't think that pain is part of MS, and pain is definitely a part of MS. And there are very specific kinds of pain syndromes. The pain is almost like a neuropathic pain. They're abnormal sensations, unusual sensations. People may describe burning sensations, you know, unpleasant. We call them dysesthesias because they're often burning, stinging, tingling. They just feel abnormal and they're very, very unpleasant. And we do have a whole class of medications that actually can be helpful for those symptoms.
I feel with my medical needs, the Avonex takes care of the bulk of my MS exacerbation symptoms, but also I've also been able to seek help through my neurologist by getting put on drugs such as Neurontin, which has really helped with my numbness and tingliness and just the sensations that I get that can be a little disruptive in my day-to-day life, as well as I've been given Provigil, which is a drug that helps if I'm having days where I just cannot seem to get up the energy to do anything, then the Provigil, if I take one of those, like, wow, that really gets me going. So yeah, I use that on an as-needed basis, and that seems to have helped.
I've had of the ABC drugs, the Avonex, the Betaseron, and the Copaxone, I've taken those for 11 years, and then I stopped a year ago. The most beneficial from my perspective has been physical therapy and simple stretching exercises like yoga exercises, the physical therapy. That to me, I wish I had done that from day one. I personally don't think I'd be in this wheelchair if I had, because that's really made a difference.
In our internet-based society, people find alternative approaches, whether it's alternative approach for the disease-altering or alternative approach for the symptoms, from ginkgo onward. Is there a role for some of those, or no?
I think so. I think people need to do what helps them. I mean, quite honestly. And, I like to be honest and tell them we usually don't have placebo-controlled trials that prove that many of these approaches, are helpful.
How about marijuana?
Even though the state of California has passed a referendum, the federal government still keeps me as a physician from prescribing marijuana. If you're asking me, you know, do I think that it actually improves spasticity? We actually looked at this, and what we did find was that there was a benefit in terms of the spasticity. People actually felt less stiff. They actually were less stiff on our examination, and that actually has been the piece that's usually missing in most clinical trials. The patient might have felt better, but the neurologist couldn't find it. But we actually found it, and so I mean, I think that's part of the exciting results.
There are a lot of alternatives out there for individuals with MS, and initially my doctor said, Mark, there's no cure for MS. You know, you have it, deal with it. So, you know, kind of stay away from the snake oil salespeople and stuff and all that. And so what I do is I take a water aerobics class 3 times a week. And the water is at a consistent, like I think it's 85 degrees. And it really feels great. It feels good on the, you know, cools the core, and there's no gravity, which is a big benefit, you know. I would have to say, you know, the exercise, definitely, if you can move, to exercise. You know, use it or lose it is kind of where we're at with that.
I want something that will stop the progression. And I also feel that more needs to be done with things that you can do that are not pharmaceutical answers. I don't think drugs are always the answer.
When I was first diagnosed, I was very open to alternative medicine and alternative treatments that are out there, and I researched it pretty extensively, and what I found through researching it was that it seemed a little complicated, a little complex for me to embrace that fully, because the diet was very rigid, no animal fats, only game animals like rabbit and things like that, like things that I couldn't go to the regular grocery store and just pick up, as well as a little expensive, I would imagine. So I did research it, but then I think I decided I'll go with the Avonex, the big drug companies, like they won, so that's fine.
And the very basic exercises, or anyone that does yoga is used to some very simple poses, very simple stretching, but it is very beneficial. It really makes me feel much better, and I'm able to use the cane for a few hours versus the wheelchair.
I think yoga is really good just for your mind and for your body. Stretching is very important. It does help with the balance. Yoga also helps a lot with just relaxation. I do find that eating right and just basically maintaining a healthy lifestyle, whether that's, you know, whatever you can do to exercise-wise. Some people can't. I can't jog, but I can get on a bike. My legs don't go numb on a bike like they do if I walk. So it's just an approach that most people, you know, should take anyway. Just look after yourself and take care of yourself and drink plenty of water and try and get as much sleep as you can, you know, the basic stuff.
Yeah, in the very short term we have left, and I must talk about, and that is, you sort of alluded to it, and that is insurance. And the implications of having MS as a diagnosis, and how much does insurance cover, and what do people have to know about?
One of the reasons that we work so hard at making sure we have the right diagnosis is that I'm really loath to put in anyone's medical records MS if they don't have MS. And I think that's really important, because as I try to explain to people, you know, in the old days, if you had MS, we used to say things like, well, I think you have a touch of MS, you know, no big deal, you know, that kind of a thing. The difference is that now, if you have MS, we're talking about therapy, and we're talking about very expensive therapy. Therapy that runs to $20,000 a year, and it's injectable, and it suppresses the immune system. So, I mean, we really don't want to put people on these therapies if they don't need them. I think the second thing I always remind people is that insurances are often looking for any reason not to insure them. And we didn't have that problem to deal with years ago, but insurance companies are getting very shrewd. They're looking for ways to not insure you.
On top of everything else.
On top of everything else. So,
wow.
So that's the kind of stuff that we're really thinking about, and that's why we really, I think neurologists and especially MS specialists feel, you know, very, that it's very important that we make sure that if we say someone has MS, that they really have MS. That's number one. Number two, I think your other question is, you know, probably the more difficult one for me to deal with, because I wish I could tell you that all insurances were created equal and that they're all paying for things equally, but it is a struggle and it is getting worse. That's really, I think, what I'm finding. We are spending hours and hours a day getting prior authorizations for medications that in the old days I could just write a prescription for.
My insurance experience has varied over the last several years. When I was first diagnosed, I was on my own insurance through my work. Thankfully, though, I had the foresight to select a PPO as opposed to an HMO, so that gave me a lot more flexibility and a lot more personal preference or personal choice in who I want to see.
My big question now that I'm changing over insurance is that, do I continue to do the shot because it's really expensive? I've heard everything from $960 a month to $2,000 a month. It kind of depends on where you get it.
Having a disability and having Medicare, Social Security disability, it's a blessing that it's available to people, but at the same time, the medications aren't covered a lot of the time or partially covered. So your deductible and your co-pays are so high that the out-of-pocket cost for an individual with MS is huge, sometimes extremely, financially, debilitating.
If you could look into your crystal ball, what do you see in the future? There's been a huge change in the last 20 years. What's coming in the next 20, 50, 100 years for MS?
Well, I think that in the future we're probably going to be able to identify people who are at an increased risk for developing MS. And I think that, obviously at that point in time, we're going to want to start therapies earlier. Start therapies even before they begin to develop symptoms, which sounds crazy, but in fact, I think it's going to be before the inflammatory cascade really starts.
Well, that sounds to me an ounce of prevention.
Yeah,
it still has got to be better than the pound of the cure.
Absolutely. I think if you asked patients what the future should hold, they would say a medication that's not injectable. And really to that end, we actually may be closer than you may think. There are really several oral compounds that are in testing right now, actually in phase 2 trials, one set to begin a large phase 3 trial. So I think probably being able to do away with the injectable medications and having a disease-modifying therapy that's oral would be a marvelous step forward, I think, as far as patients are concerned.
I don't think that they'll cure MS because they don't really know it has an unknown etiology. They don't know what its cause or what's going on with it. You've got to learn to do the best that you can do for your quality of life with what you got going. And if you wait around for a cure, you're going to be then you're waiting with bated breath for that to happen. And I don't think I don't see it around the corner. But you never know. It could be tomorrow they come up with something.
Any other things that you're looking forward to in the future that you think would be exciting?
I think that if we could, I think actually monoclonal antibodies are probably going to be the near future. We already have one on the market, and I think that what we're going to see are these very specialized monoclonal antibodies being used to actually affect the inflammatory response in the brain.
These are big deals.
Yeah.
I feel like we already live in the future. From back in medical school to now, this is already science fiction, some of the things that we're doing. So I don't know if everybody realizes it. It's very exciting to be able to offer these treatments that you have.
I think the most important thing is to keep pushing yourself. Keep challenging yourself at whatever level. That challenge may be very basic. How to get up a 6-inch rise in a stair or whatever it may be. How to step into a bathtub.
I feel like I could either be discouraged and depressed and down all the time because I have this disease, or I could take a positive spin on it and say this is what I have and make the best of it. And that's what I do every day, is think, people are a lot worse off than me, and I have it for a reason. And if that's to help other people that are just being diagnosed, then that's why I have it. If it's to make me appreciate my life and my son every day, then that's why I have it, and I wouldn't change it.
You got to take it in small steps, and you just gotta. It's kind of like anything else. If you get too stressed out, you got to just take a couple of deep breaths and just relax.
I think, as with a lot of things, the MS kind of is what you make it. It really isn't to an extent as well, because I know that it's really out of our control, but I know that Perception is everything.
Being with the kids is the greatest positive out of all of this, you know. Hanging out with the kids, seeing them growing up, like you would just expect yourself to do as a parent. And that's the most positive thing, you know. I think it's brought my wife and I closer together too.
There's a lot of us out there. And if the more that the public is aware of how we are feeling and how we are adapting to the situation, I think the better for everybody. I would rather not have the MS, but I'm not going to stop living because of it. Or as the saying goes, I have MS, but MS does not have me.
Thank you so much for taking your valuable time and spending with us today to educate folks out there. It's greatly appreciated, and for all your work.
Well, thank you. I enjoyed it, and I was really glad to be with you today.
You've been listening to Professor Jody Corey Bloom talk about MS and also about an approach to taking care of a disease, which is really important to remember. I'm always astounded when I have such an outstanding expert and professional sitting here about what a difference it makes to have somebody know what they're doing and understand a disease and understand a person when they talk about what they do. So for you at home, remember, knowledge is power. The more educated you are, the more you can work with your doctor as a partner in your care, the better your health will be. I'm Dr. David Granick, and we'll see you again here on Health Matters.